So are they in? All right. So welcome everybody to the sixth and final of our series on global primary care delivery, which is a joint initiative of the Department of Family Medicine and the School of Population Global Health. Marion Dove is the chair of the Department of Family Medicine, and Tim Evans is the director of the School of Population and Global Health. And thanks to their support throughout the series. I really appreciate it. So before we begin, I'd like to take a moment for recognition and reflection about our land and the time that we find ourselves in. McGill, as you know, is located on the unceded lands of the traditional territory of the Kunyankiaka, a place which has long served as a site of meeting and exchange among nations. And we honor and respect all peoples connected to this land and are grateful for the opportunity to live here. We also acknowledge our privileged positionality and how our actions can perpetuate settler colonialism. Our silence and inaction can only contribute to the eraser of the realities and histories of Indigenous peoples. Unfortunately, the recent discovery of the bodies of 215 children who perished in the custody of the Kamloops Indian Residential School in British Columbia is part of our unconscionable history of injustice against Indigenous people in Canada, which has extended from our first contact to the present day. And the impact of this news and the truth of our country has been powerfully felt across our university, across our community and nation, and our shock, grief, and contrition is, however, secondary to the pain and anguish of affected families and communities and residential school survivors everywhere. So we need to listen to and ally with Indigenous peoples to help end the discrimination and historic injustices they've endured. We also must critically examine our own leadership policies and practices to find ways to uproot the systems that perpetuate this injustice, and they are systemic systems. So on that note and somber note, I'd like to welcome you to today's series. Just to remind you that this is one of the last of six, started in January. And our goal was to engage faculty, students, and primary care clinicians and the broader Montreal community in critical discourse around local and global innovations in primary healthcare. And we brought invited speakers through the webinar series to share their experiences. And then there was an accompanying set of workshops where we discussed some of the webinar themes more informally and also looked at pre-selected readings. And the recordings and summaries of those events are available on our Family Medicine website. Thanks to the pandemic and our opportunity for virtual exchange, we've had people from all over the world join us, from Bangladesh, Liberia, US, and across Canada, also the UK, and heard about all sorts of topics, including community health workers and their incorporation to health systems, Indigenous approaches to primary care. Social prescription was one of the more recent ones, and also looking at new models of technology-enabled patient-managed care. And I think we've learned that there is a lot of demand for knowledge sharing initiatives like this, and it is important for us to take opportunities to animate primary care principles in addressing primary health disparities, and we see these particularly amplified in the context of the pandemic. Our last workshop is on next Wednesday, and there we'll be taking some time to think about potential next steps for this emerging local, global primary healthcare community of learners and practitioners. So I hope you'll join us in that discussion. And then I think the last thing I'd like to do is just take a moment to thank Brianna Cheng and also Yasmin Elmer, because they've been really fundamental in organizing this series. I'm really grateful to both of you for helping conceptualize and organize from the very beginning. So thank you. So this session's on health justice, and it will be facilitated by Tim, who's the director and associate dean, as I mentioned before, of the School of Population Global Health, and he'll be joined by panelists, Linda Redwood Campbell and Sabina Fayez Rashid, and I'm going to call them Linda and Sabina because I've known both of them for a very long time. So apologies for my informality, but it's easier that way. And we're going to learn and listen to them and about their lived experiences working with populations in precarity. And they're going to be asked to reflect a little bit on primary care and how it could be reconceptualized to meet, delivered and scaled to meet the needs of these populations more fairly. So Linda is a family physician with research, scholarly, and international expertise in global health, immigrant and refugee health, and humanitarian response. And she's worked in many resource-poor countries as part of several emergency responses, including the 2004 tsunami in Indonesia, the 2005 Kashmir earthquake in Pakistan, and also the 2010 Haiti earthquake and cholera outbreak. So she's had a vast experience, and she continues to lead global capacity building initiatives, a focus on health, human resources, and primary care delivery to the present. And Sabina is the dean of the BRAC James B. Grant School of Public Health, which is part of BRAC University in Dhaka, Bangladesh, a home of Tim and myself as well. She's also a great friend. She specializes in ethnographic and qualitative research that looks at the impact of structural and intersectional factors on the ability of marginalized populations to realize their sexual and reproductive health and rights. And she founded in 2008 the Center for Gender, Sexual and Reproductive Health and Rights, and also co-founded the Center for Urban Equity and Health. And thank you for joining us, Sabina. It's late there in Dhaka, so good that you're a night owl. So
I'll do anything for you guys. So thank you for having me here.
So Tim, please take it away.
Great. Well, thanks, Elena, and thanks, Yasmin and Brianna. And I also just want to acknowledge my co-host in the series, Marion Dove, who's chair of the Department of Family Medicine. And she's given me the opportunity to moderate this session. But I fully expect her to come in and point us in the right direction if we get lost. But that's impossible because we've got two great speakers, as Elena has indicated. And so we're going to dive right in. We're going to try and orchestrate this as a conversation. So we don't have any PowerPoint slides, just a lot of powerful points that we expect will come through from the speakers. But we also rely on the chats. So as issues arise, please get your questions or your comments into the chat, and we'll try and bring those in as the conversation moves along. But I'm going to begin with sort of an introductory question, which is asking both Linda and Sabina to reflect on how primary healthcare services can not only be delivered, but delivered at scale to really address health and development needs of people that are in precarious or emergency settings, and understanding that access and scale have dimensions related to accessibility and quality. So I'm going to begin with Sabina. Give us some reflections from your own experience on that front. How is this being managed, and what insights can you give us with respect to the challenges, particularly for people in precarious situations?
Thanks, Tim. Good to see you guys again. Tim was my boss, actually. For a couple of years ago, and Elena's been a very close friend. Good to be here. I want to change the question slightly, Tim, because I'm experiencing, we're living in COVID, all of us in different ways in different countries. And what I find is I want to take a step back, because when we look at disadvantaged or vulnerable populations, and I mainly work in informal settlements, and in fact, Elena and I've worked closely for many years, and I continue to work in informal settlements, which are sort of urban slums. These are people who have migrated from rural areas to cities. And Dhaka city, the capital, has the largest numbers of informal settlements. They often don't have the right to reside. They can be evicted. It's usually overcrowded. It's congested. There's lack of basic services and facilities. So in this context, if I look at COVID, the reason why I'm bringing this in is because often we talk about services and efficiency and effectiveness, but I want to talk about what vulnerability does to people and how do we understand access more broadly. If we're going to use a sort of a social justice perspective, I think we need to understand the basics. So during COVID, the entire country shut down last year for about 4 months. And what happened was the informal settlements shut down, and you've got millions. You've got about 7.5, 8 million living in Dhaka city of the 16 million in these informal settlements. And for them, starvation was a bigger risk than the fear of COVID as a disease, okay? They were worried about what they were going to do, how they were going to eat. One of the effects was health systems is already weak in our country. There's poor governance, poor quality of care. Yes, there's a shortage. So newborn mothers were turned away and they couldn't get vaccinations for their babies if they could even leave their homes. You had people with disabilities who didn't have access to caregivers because of the lockdown, and accessibility made it difficult. Transportation was shut. So I want to just kind of unpack when we talk about health services that really we need to understand context. And context is so important because often we stop at services. And I'm sure Linda can add to this, working in many crisis situations, that the basics are often missing: food, shelter, negotiating with your landlord for rent, managing food, having no jobs. Health is one of the multiple risks in their hierarchy of lived experiences. So intersectionality, I'll end very quickly. Intersectionality is very important because power, position, location, class, your age, your disability is a huge factor. I can sit and do Zoom with you in my house. I don't have to worry about the roof over my head, my food, my job. But for the poorest, it's competing multiple risks. And then health systems or health clinics come in after we deal with some of the basics. So I just wanted to kind of raise that as a discussion point.
Great. And thanks, Sabina, for providing that context. And I just want to reemphasize the numbers: 7.5 to 8 million people living in informal settlements. I think that means that's more than the population of Quebec, or about the population of Quebec, where we're having where McGill is located. So, Linda, over to you. Sabina's giving us a strong sense of context. How does that resonate with respect to your experience with the various emergencies that you've been faced with?
Thanks very much, Tim. And Sabina, I can very much relate. Absolutely. Context is, they say context is everything. And, if I think over the years that I've been working in the area of disasters, emergencies, and primary health care, if I take a step back and I think about why are we working in this context, and I think most of us that are talking about primary healthcare systems and models are thinking about it from a health equity perspective, thinking about it from social justice. And I think one of the things for me that's often missing when we're talking about developing primary healthcare systems, specifically in precarious and emergency settings, is that its context is very different than a stable environment. And so that context piece for me is really important. And the disconnect that I think I've seen, in my own personal opinion, is that we've got primary healthcare and the system development. And then we've got this whole thing called emergency disaster risk management. And that is the whole idea that you take multi-sectors and multi-disciplines with lots of different, pulling in lots of different kind of agendas and policies to actually be thinking about the communities from the perspective of risk. And Sabina, you mentioned the risk. And for me, risk is actually a really important one that I actually think we need to bring better into the context of primary healthcare systems. So you've described really nicely what's happening in Bangladesh and Dhaka in terms of the population and what's happening, but the risk associated with that. The other thing I'd add with that is thinking about what about the other risks to that community? What about the risk of natural disasters? We know certainly Bangladesh is prone to natural disasters. And how do we identify risk? both, and then be able to mitigate it, plan for it, respond to it within the context of a primary healthcare system. So those are some of my ideas and thinking about how that all comes together. So I think, Sabina, your context is really helpful for me to think about it in my head.
So excellent. Two perspectives where we're bringing in the bigger context, so we can't avoid that, but also doing that in a way where we're not only dealing with current risk, but looking at prospective risk and bring that. So bring this now down to the ground. How are each of you factoring in context and thinking about making changes such that opportunities for primary care are more likely to happen in these challenging circumstances?
Want me to go first?
Yeah, absolutely.
Okay. Now, I was going to say with Bangladesh, we have a history of some very, very innovative, simple solutions and innovations working with the informal providers, the drug sellers in tackling, something like tuberculosis. We have a history of community engagement at different levels. When we're talking about context, this is why it's important when we even look at primary healthcare, if we unpack what health systems look like in different contexts. In the Bangladesh context, a large percentage go to drug sellers. So how do we then engage with drug sellers to get them to do referrals to clinics? Or how do we get to engage with other forms of informal providers? How do we use like BRAC community health workers throughout the country who become a huge bridge between informal settlements, rural areas, and linking them up to government clinics and health facilities? I mean, we have a history of community engagement and successful oral rehydration therapy programs, tuberculosis, and other forms of, I know that Elena, you did some work on that urban atlas, where you mapped out for the government informal providers so they could set up much better implementation and reach. The difference with COVID, I wanted to share was COVID is socially driven, but the initial approach to COVID was very clinical. It was about wash your hands, wear masks. And now for slum context where you don't have space to distance, you can't afford masks, you don't have soap and you can't constantly buy soap, you have erratic water, those sorts of factors don't take in the social aspects, the economic aspects of lives that allow to understand health more broadly. But we actually, Bangladesh was featured, as you would know, Tim, you and Elena were involved in that Lancet Commission on Bangladesh's success story. And one of the things that a lot of the NGOs and many of the sectors in Bangladesh worked with was communities, diverse communities, and taking into consideration different actors in the communities, whether it's religious imams, whether it's local leaders, whether it was young boys and youth, whether it was adolescents, and whether it was like community leaders. And I think that's always, it makes sense if you work in any community, indigenous, if I look at, when I first graduated from ANU, the Aboriginal communities, you need to work with communities, not about them, not on them. So they don't become objects of study. We work with them and learn from them. Thank you.
Great. So Sabina, I want to come back to a couple of issues, but we'll move to Linda to get her insights on things. But I just think one of the things you're identifying is that despite tough circumstances, there's an abundance of resource and resilience in communities that you're pointing to. And I just want to also clarify that drug sellers are not illicit drug sellers. They are informal pharmacists in that sense. Linda, over to you to ground us in your comments related to bringing emergency disaster risk assessment and PHC more in line.
Certainly. Thanks very much, Sabina. I love hearing your context and story. For me, actually, I've been very involved with a partnership in Indonesia for a very long time. So I'm a full-time faculty member in the Department of Family Medicine at McMaster University, and we have a partnership with a university in one of the provinces in Indonesia called Aceh province, and the university is called Sekolah. And Sekolah University is situated in the area that was significantly affected after the Boxing Day tsunami and earthquake of December 26th, 2004. And that partnership that developed since then. And what's actually happened over time is that in the context of Indonesia, I don't know if you know the context of Aceh, I'll just briefly mention it. So 30 years prior to the tsunami, Aceh province was an area of conflict. There was obviously, because it was an area of conflict, there was the healthcare system was poor. People weren't getting much care, if any at all, in terms of health problems. And the system was very broken. After the tsunami, it took a few years, but there was a peace accord that was signed. There's been really significant development. And I've been really impressed with what's happened in Aceh. I don't know if any of you have been there sort of soon after the tsunami, and now it's like a very different place. And part of the reason is that there are people very, very informed and very positive people in Aceh who want to see a change. And so what they've been able to do, and I'm going to go back to the university for a minute, is Sekolah University has really developed their capacities within the context of disaster management. So if I think about the medical school and the program we've worked with, to see what they've done in terms of their medical education program and training, not just physicians, certainly doctors, to understand community in a very different way and understand disaster risk of their own communities. They will actually send medical students, it's part of their curriculum now, part of their family medicine curriculum. They send them out into the communities and say, do risk assessments, do community events with a plan. So these students are becoming aware and informed about their communities in very, very different ways, from a perspective of disasters, disaster emergency, disaster management, disaster risk reduction, all of those concepts they're learning early in their medical training. So what's happened over time, it's not just the, and it's not, I have to be very clear, it's not just the medical school. It's, yes, all the other health professional schools, but all sorts of other sectors within the university, the Ministry of Health, all the other ministries. So it's a really interesting process that's happened in Aceh over 15 years. And it's sort of, it started, I would say, grassroots up. It's also started top down from the perspective of policies being changed, identifying primary healthcare within the context of Indonesia as being very, very important. Family medicine is actually being identified as an important specialty to develop in the country. So the things that we're seeing in those contexts are really interesting, because the students are finishing their programs and they're becoming very educated and understanding a system that I actually don't think we're doing a very good job in Canada training our for example, our family medicine residents or our public health residents. And I think we can learn a lot from those kind of experiences and expertise at their end.
Great, thanks, Linda. And it's great to hear, you know, with the benefit of years now post tsunami, what in your story sounds like evidence of building back better and perhaps fairer, because you've got a real mobilization on learning related to risk assessment and risk reduction, which transcend sectors. So one question I think for those on the call is, what do we have in place to really take the lessons of the COVID crisis and perhaps follow suit with respect to Banda Aceh, where there's been a sustained effort to try and make sure the lessons are not lost. But before, that's just to provoke Marion. I'm sure the family medicine curriculum has changed immediately following the COVID crisis. But Sabina, I want to come back to you, and again, this is not specific to you. Linda, you may have thoughts on this. In the context of an emergency and crisis, and Sabina, you mentioned COVID, how the public health dictates came down in a one-size-fits-all. Wash your hands, physically distance, and all of the things which were not even remote possibilities for people living in the circumstances. So the question is, how do communities tailor those prescriptions in such a way that they can manage risk without simply throwing up their arms and saying, this is not possible? And Linda, I want you to think about this as well, because often the emergency response is very militant and one size fits all, top down, in order to be quick and responsive. And I'd also like your perspectives on, are there ways in which that can be tailored? So if you guys can just give a few thoughts on that, would be great.
Sure. So one thing, communities, if they're heterogeneous communities, right? So they're not just one blob of a community, but in general, I find, I've been working with disadvantaged communities since my 20s. I came back to Bangladesh in '93, and they're extremely pragmatic. They're much smarter, far more resilient than you and me, and they manage. So we found cases of landlords and tenants figuring out how to rotate cooking in their congested kitchens. They found ways to take turns using that one latrine or their bathing space, where they said they would divide and stagger it because they didn't have options. And they don't, we're given these guidelines from WHO: come home, bathe, wash your clothes, and they may only have 3 items of clothing. But what they would do is try and wash their hands, try and wash their feet. They bought a lot of bleaching powder. They bought Dettol. They tried in ways to have boundaries around their spaces. 2, I think one thing it raised issues around was our risk communications was a huge failure, not only from the government, but from all sectors, because it was such a clinical management approach. They had a lot of mistrust because they were trying to manage. So masks, another example. Women used torn sari cloths, materials that we use. They use their orna. We have this dupatta that we wear over our local outfit. And they said, we're not going to spend 30 taka for a mask because that's enough to buy some food or some items. So they used local cloth. Or they made some cloths within the slum and they managed. And then they would give the one mask to their husbands who were defying lockdown to go and pull a rickshaw or to go and earn an income. So, they're smart, they're pragmatic in the absence of choices. At the same time, it raised some questions, and now there's ongoing discussions around where, UNICEF, BRAC, government, we're doing research on how do you have informed risk communications that resonates with communities. We saw this with the Ebola crisis, with the whole fears around burials. That was the major issue with this. We had a system where the police helped the health workers identify COVID patients. That is something you just don't do in the Bangladesh context, given the poor have always had a contentious relationship with abusive law enforcement officers. So now they've changed that approach. This community health workers going door to door, doing much more sort of sensitized referrals, talking about burials, talking about the rights of, certain kinds of spaces, because they were worried about terms like isolation, quarantine, there was stigma. So there was a lot of lessons, Tim. I heard you say, what are the lessons learned? And there was a lot of lessons learned. My final point is this year, the government didn't repeat and adopt all shutdown of an entire national, a nation. What they did was, and this is the reality of an economic, less resource countries, you have a semi-lockdown. Garment factories opened up because the poor said we need to work. So they're most at risk. But ironically, I was just looking up some data. When we talk about masks now, we talk about behavior change, they will say no one's dying in our slums. It's the rich who are dying. So why do you keep telling us about vaccines, and why do you keep telling us about masks? So there's a lot of messiness in this space. But the main takeaway I just wanted to emphasize is the poor are pragmatic and they try their best given the circumstances. Thank you.
Thanks for that.
Sabina, can I just ask a very quick question, may I, to Sabina?
Please.
It was just a quick question. Is it really true that the rich are dying, or is it that we're not capturing the poor that are dying? I don't know the answer, so but I question that.
Yeah. So the problem is that we have very low testing, right? To some of the surveys done by ICDRB and others will say that actual mortalities are not that high in slums. So whether it's COVID or not COVID, there are different kinds of morbidities happening. So there's a puzzle going on. We don't know now because of the whole recent variant that's happening in India, what's going to happen to us. But so far, in terms of deaths COVID related, and people are saying, is it vitamin D? Is it that they have high immunity compared to? And in my case, I hear a lot about cases of the well-off who have filled the hospitals. It could be just my networks that tell me about an aunt or uncle or a friend or a relative. And the poor just don't go to these services. But in terms of the kinds of deaths we saw in Brazil and favelas, or even in Dharvi slums in Mumbai, we didn't see that same level in Dhaka as yet. So it's very hard to say, sorry, Linda.
No, I think, but it raises, I think, Linda, you're raising issues on what are the surveillance systems which might pick that up, and the degree to which you've got comprehensive information systems in some of these precarious circumstances is important. Linda, I'm going to extend this to you, but I know Marion's hand is up, and Mary, do you want to get in before Linda comes in?
I was just going to address some of the questions that were raised about family medicine training, and I don't know if you want to hear that now or if you want to hear that later, whatever the flow seems to.
We're gonna move in that direction, and so please keep that. But I did want to get back to Linda in terms of really sort of hearing just a little bit more from her on this contextualization to the community setting and the context of the efforts to build systems that have universal standards of quality and access, et cetera. So the emergency setting is very top down. And what is, in your experience, how do these things contextualize really to promote that access, and perhaps what Sabina's identifying is the strengths and resources that are inherent in a lot of communities that may otherwise be overlooked?
Absolutely. Sabina, you also mentioned resilience, and I can't say how incredibly humbled I've been to see the resilience in almost every single community that I've ever worked in emergencies and in disaster settings. I think for me, it's interesting to see what's happened over time in terms of humanitarian response. And I think it's getting better. I agree, Tim, it tends to be very top down. If I think about even 10 and 15 years ago, the disaster response was the big international organizations showing up and sort of setting up and doing their thing. And over time, we've learned some really important lessons about that. I think the big organizations have realized that that's not the way to do it. And we can't go into these, we meaning the international community, if we're going to be supporting just any kind of disaster or humanitarian response in whatever country we're going into. We are guests and we are supporting, whether it's the local government, whether it's with the local Ministry of Health, we should be having that mentality and nothing else. The 2010 earthquake in Haiti was an absolute disaster, again, on top of a disaster because of the international humanitarian response. It was absolutely unacceptable. And even if I think about the health response and how many thousands of organizations came in to do health response with no understanding of the community, no understanding of what the community needs really were, and then left without continuity for individual patient care. It was an absolute mess, and that's why some guidelines and some technical guidelines sort of came out of that. But I think when I think about the big organizations, and certainly some of the ones that I've worked with, I do see improvement over time in terms of being more flexible and being more able to take a step back and not necessarily, and there's a lot of political pressure when we're talking about humanitarian response and what countries are going and what organizations are going, and to kind of wave their own flag. But I think there's more understanding now to take that step back and say, what are the actual needs of those communities, and would our organization or our government actually be helpful there or not? And ideally, have we been invited in to go and do that? Depending on the context, there's some challenges with that, but certainly those are the things. So when I think about an organization like the Red Cross, the Red Cross movement, the International Federation of the Red Cross, encompasses many 180 odd what they call national societies that have, and some of those have capacity to actually deploy, they use military terms, to, for example, a field hospital in these settings. We now know that, and I think the Red Cross knows that sometimes it's actually needed, but a lot of times it probably is not. And it's more about how do these organizations best support the current infrastructure, and how do we create in a situation where we're doing more support and partnership together, rather than creating an environment that is not good for, and making the actual community worse off than they were before. And though I've seen changes like that. I think about 2 years ago, I was in Mozambique after the natural disaster there. And I was with the Canadian Red Cross International Emergency Response Team, and we were in the rural part, actually, in a place called Namatanda, and the whole purpose was to support the rural hospital there. But essentially, what ended up happening in Mozambique was actually the program, and it became capacity building and building their own capacity. So it quickly it was clear that the best thing that they could have done in that context is build local capacity, and specifically in that context, it was around maternal child care, and it was around training technical medical officers in Mozambique who are in rural areas to be able to do better obstetrical care, including cesarean section. So I think that the organizations are thinking differently about how do we do that. The Red Cross talks about the last mile, and how do you identify the people and the populations that are the most important and the most difficult to get to, because those are the ones that often still get left out. So I think there's I definitely think we're coming along the way, Tim. Are we there yet? Absolutely not. I think there's a lot of work to be done. Ideally, that we won't ever need an international humanitarian response. That's the goal and the dream. But certainly regional response would be most appropriate if needed by the host country. So just some thoughts. I could go on.
No, I appreciate that. And so I guess I want to shift the conversation. We've had rich insights on context, but we're sort of an academic health center, and all of us have links to that. I think that's one common denominator, perhaps, of most people on the call. And Marion, I want to bring you in here. We were challenging you on family medicine and what it's doing to embrace emergencies. Many people would say emergencies are going to be a much more regular part of our life moving forward, not just because of COVID, but due to other sorts of circumstances facing health systems. How are you thinking about incorporating this into the training of family doctors? Sabina and Linda, from your also academic perspectives, to what extent has your educational environment been a facilitator to engaging with emergencies and dealing with precarious communities or communities facing disproportionate disadvantage versus a barrier. And so are education institutions really on the vanguard, or are we perhaps holding things back? So Marion, why don't you kick us off with a few thoughts on family medicine, and we'll go to Sabina Linda on that front.
Thank you, Tim, for that very thought-provoking question. So for those of you who might not know, before I became chair of the Department of Family Medicine, I was the director of the Family Medicine Residency Training Program at McGill. So I have a bit of knowledge in this area. Just to quote someone that I heard speaking when we were trying to revamp the undergraduate medical curriculum at McGill in 2013. The quote is that it is easier to move a graveyard than it is to change a curriculum. So just to keep in mind that it's not easy. The standards for both medical student education they're set nationally. The standards for family medicine residency education are set nationally. These standards and these learning objectives require a huge consultative process to be changed. So are we going to be able to respond quickly and change the way that we're training residents within the next few months because of the COVID crisis? No, absolutely not. But I would say that within the family medicine residency training program, one of the goals of training residents is the development of what we call community adaptiveness. And this is part of the College of Family Physicians Family Medicine Professional Profile, that family physicians should be community adaptive, should be responding to the needs of their community, and residents are trained to look at, to understand quality improvement, to look at the needs of the population, to focus their training and their learning objectives on what their community needs. So I would say that this is probably actually the best that we can do, because we will never in Canada be able to train our residents for every possible disaster or humanitarian crisis that can arise around the world. But I think what we can do is ensure that our family medicine residents, when they graduate, are able to learn what they need to learn in particular situations, both internationally and locally.
Thanks, Marion. I want to switch now to Sabina, as you're a dean of the School of Public Health at Brack University. How are you guys managing training for emergency settings?
So I joined, I mean, as you, Tim and Elena knows this history, I joined in 2004. So I'm a medical anthropologist by training. And one of the advantages of the Brack James P. Grant School of Public Health has always been the fact that it's not 200 years old. So we don't have to deal with layers and layers of, as you put it, graveyards and whatever else. There's space for innovation. And also the original vision of the school was direct immersion in communities. That has been from day one. So our first MPH program, which is sort of half international students from all over the world and half Bangladeshi students, doctors, non-doctors, people from various disciplines come in. And every course, and now even more, have structured immersive learning, where there's direct exposure to either spending time in a health facility in a rural area to learn directly from practitioners, or visiting hospitals or talking to communities. That's been a huge advantage. I'm going to get to COVID very quickly, but that's been a huge, I've learned along the way, because a lot of our students are also been working in the field, and they come in with different experiences from South Sudan, Afghanistan. Another thing that I'm going to share the positives first, in case you think I'm just plugging the school, but many of our graduates have gone on to deal with the Ebola crisis in Liberia. They're running midwifery programs in Afghanistan. They're working in Pakistan. So that makes me really proud. I think what the challenges are about COVID, and I think it also affords opportunities, is that we can't do the field work. We are thinking of a blended program later this year. if COVID is controlled enough, maybe in the second half after October, November. What we've done is we do a lot of research at the school, and we use data transcripts for students to immerse themselves in data transcripts to understand firsthand, or at least we can say secondhand through data transcripts, how people are experiencing their lives. Another thing we're thinking of doing, and Elena, you taught the qualitative, and there's many different ways that we've addressed this, because we have a lot of databases and data surveillance systems and ongoing data. So we're trying to use data transcripts. We're also trying to do phone interviews, getting students to phone interviews, work in groups to learn from each other on different situations in COVID. My final point is one thing that I've realized teaching in COVID, during COVID, or during a pandemic or crisis, when you teach online, you have to be much more empathetic, because students are struggling and they come from all over the world. And this is a good opportunity to introduce in curriculum the ethics and the values and the ethos of what public health is and why they've come into this field, because COVID magnifies the structural and social inequalities and inequities that have decimated and impacted on so many populations. And I think this is a good time. We've done it, but we're strengthening it. Why is human rights so important? Why is social justice so important? Why do doctors and non-doctors need to think beyond biomedical? Why is social is as, or if not more important than the disease for those who are vulnerable? Final point, we're also looking at why we need to look at information, communications and information, because there's been so much misinformation through social media in populations in Bangladesh, but across. And I think it's important public health skill, amongst many others that have been mentioned. And mental health and emotional well-being is something that is critical as we move forward. So these are just some of my thoughts and some that we're working on, but it is an opportunity to critically reflect. My final point, Tim, and I'll shut up, sorry, is the one thing I realized living and working in Bangladesh for a long time is sometimes you forget that knowledge is multidirectional. So there's a lot we can learn from each other. It's not just the global north feeding the global south, but what can we learn from the global south? What can we learn from Southeast Asia? What can we learn from Taiwan and Vietnam around COVID? Because they were very successful in managing many of their sort of health systems. And I think it's time to open up and have those critical discussions. We also need to talk about global accountability and governance at a global level. So there's a whole list, and it's going to take us time, but I think it opens up many opportunities to have those discussions as leaders and as heads of institutions across the world. Thank you.
Thanks, Sabina, for that. And it makes me feel that I'm going to have to re-enroll in the MPH under your leadership, because I think all of those things are critical lessons which we need to incorporate actively into our formal learning system, as difficult as that may be. But the risk would be we squander the opportunity to take advantage of that learning. And the other thing I think you made very clear is that if we think about learning systems globally and their accessibility, then I think the opportunities are not related to our specific contexts. And there's lots of valuable learning in that regard. Linda, you've had a very direct relationship with institutions that are part of the international response. And to what extent are academic institutions like the ones we're part of helping those institutions actually become more effective in their work? Are we providing them the sorts of training that they need and require? Or are we, as Marion was saying, perhaps too slow to respond to the sorts of challenges they're facing?
That's a really good question, Tim. And I would say that there's a lot of work that we could be doing that we're not doing at all. Even the context of the training programs here in Canada and thinking about what are the competencies that we want our residents to know about. I don't think we've been doing a good job. And just when we heard from Sabina about the teaching and training community public health concepts and primary health care. I think that's done in low-income countries much better than it's done here. So I think I actually feel, Tim, like in the academic institutions in Canada, in terms of supporting international response, we've got a huge amount of potential work we could be doing. I think we're just literally hitting the tip of the iceberg right now. So I would say that certainly right now, what we're doing in McMaster, I've just taken on the role of Director of Global Health for the post-grad medical education. And we are looking at the curriculum that we're teaching all of our residents across all of the programs in terms of global health, and thinking about it from the local perspective, and thinking about what are the competencies that we've actually been, that we've seen recently with the pandemic, that our residents are now developing, and how do we continue that development? So for example, I mean, I think about how do we teach our residents to be working in a more dynamic environment where we might not have the data we need to make decisions, but that's the reality when you work in an environment like this pandemic? Or how do we train residents in competencies to say that the care that you're providing is good enough? And you might take a step back and say, well, it's actually, is the quality good enough for compared to what we normally would do? And thinking about the standard of care right now, and we're doing a lot of video visits and those kinds of things, and we're teaching residents to do that kind of response and care right now. But is the quality of care where we want to be right now? So there's lots of competency areas that we could, from the perspective of building programs within Canada. But I think that institutions in Canada, in the universities in Canada, could be working more closely with the various different, whether it's an NGO, whether it's government organizations, to actually really think about the implications and the research questions that we have in terms of these kinds of responses.
Great.
So I'm aware of time, so.
Yeah, no, excellent. And I do want to just, Renee Plaza it has a question. Renee, do you want to get that question in quickly if you're available on the Viva Voce live voice?
Hello.
Hi. Do you want to ask your question, Renee?
Oh, sure. Thank you. Again, I'm following you. I'm a physician from Ecuador. I'm coming from a low-setting country. So my question is for Linda. It's very good to listen to her input, and I want to know if the emergency framework can be applied in different low-income settings to reset the systems or improve the healthcare systems without actually having a natural emergency or disaster. Sorry, hi.
Great.
Thank you, Renee. That's a really great question. And the answer would be absolutely, because if we think about developing health systems, there might be other kind of risks in your community. So we're thinking about identifying those risks. We're thinking about mitigating what they might be. And it doesn't necessarily need to be a disaster, like a natural disaster or a complex humanitarian emergency, but certainly risk management and mitigation of risk is going to always be helpful to help develop a very strong, robust primary healthcare system. Now it's interesting you're from Ecuador, because I know I'm thinking about family medicine in Ecuador, and maybe you can fill us in a little bit. I know they've used sort of an equity model in terms of distribution and training of family doctors in Ecuador. And I don't know if you're involved in that or if you know anything more about that, but certainly I've heard from a colleague of ours in Brazil, who's Dr. Adelson, who's just been talking about that and his work in Ecuador.
Yeah, actually, that's why I'm here in Canada, right? It's because the family medicine program in Ecuador is not qualified. It doesn't have all the tools that they need to have to train the doctors. It seems that the family medicine in Ecuador is the lowest of the lowest in the primary care, and we are trying to change that. So there are more programs in Ecuador that are encouraging people, they're encouraging the doctors to be trained and to be the first step to for the patients to get access to healthcare. However, there's so much to do, and that's why I'm here in Canada. I'm pursuing a spot to be trained and to learn new strategies and how to bridge this knowledge and transfer knowledge to people to improve the healthcare systems. Thank you.
Great. Well, listen, we're just slightly over our time, but Renee, thanks for that question and thanks for your engagement. I want to thank both Sabina and Linda for illuminating really sort of what I would perhaps without trying to be superficial, but looking at what is really the opportunity in a crisis. And I think three types of opportunities have been identified through this conversation. The first is the opportunity to recognize that between the emergency response and moving to systems that are more responsive and sensitive to needs, there's much more of a unity than a disconnect. And so how we seize that opportunity is really important, a little bit like Renee was suggesting. I know, for example, in the Ebola crisis in West Africa, one of the silver linings related to the crisis is that you could get commodities, essential medical supplies through customs at lightning speed, as opposed to them being held up for 12 months. So this was something that was part of the opportunity. The second opportunity, I think, is to recognize that all communities have tremendous resilience and resourcefulness if you're willing to recognize it. And I think this is the opportunity of context and redesign, which is engaging and working with those communities as resources and seeing that diversity as a richness as opposed to purely disadvantage. And so I think that came through. And the third opportunity, I think, is recognition that this work is not at the bottom of the priority line in terms of what counts, and only to be done by those who think this is charity. This is actually work that defines the behavior and the integrity and the trust of a system. And those that are involved in developing the competencies to work in these settings, which require competencies that are not necessarily coming from training as we've known it in the past, need to be given the recognition and respect that this is work that is valued in the context that we see careers, promotions, and things in the settings that we work in. So three great opportunities from our guests today, Sabina and Linda. Thank you so much, and thanks everybody for your participation today.
Thank you.
Cheers.
Thank you very much.
Stay safe. Thank you very much.
Cheers.
Bye-bye.